On-the-scene coverage of ACC.13 is supported by Janssen Pharmaceuticals, Incorporated.
Question, please.
Christina Fiore with MedPage Today. I know that you were talking about still looking into subgroups and who might benefit most from which procedure. Many of you work at centers which have experienced surgeons in both procedures now. So how are you clinically deciding who is going on and who is going off?
Hanno?
We decide in our hospital we have two excellent off-pump surgeons and a lot of good on-pump surgeons. Those patients who are older than 75 years still going to off-pump more than to on-pump. Those patients with general vascular disease, because we knew that the stroke rate is much higher in those patients, and we knew that it is a surrogate for sick patient anywhere, they go to off-pump as well. By figures, we always have better results in our centers for off-pump than for on-pump. This is, of course, not a study, it's biased by selection, but we feel that we do the right selection of the patients. And that was what the panel discussed today as well. You need some expert surgeons, and then you need for your hospital, for your environment, the right selection of patient, and you get maybe a feeling from your data, if you reflect your institutional data, which patient should go to on or off pump. And that may differ in each center. It's hard to prove that in a randomized trial.
Andre?
Well, if I look at my data, like we have Germany, we have Czech Republic, but if you look at the data, the results in Canada, out of 830 patients, it's a 35% reduction in primary outcome with off-pump, and that's positive. If you look at the results in North America and South America and Europe and Australia together, there's about a 20% reduction. It is positive. So we don't know exactly yet what is driving the whole thing. So we know that Euroscore is one of the main driver, but there's more to it. And I personally, that's the next few years that would be my goal to try to figure out exactly which patients do and do not benefit from off-pump. In my personal practice, I use that. And usually I switch when my Euroscore is 3 or more, I switch to off-pump. And less than that, I go on-pump. So it's not unusual for me to do an off-pump in the morning in a frail patient and do an on-pump in the afternoon in a younger, more robust patient. So, and I think that's the real message for me is that, adjust yourself to your patient and be able to do both technique. No, don't be a single one-trick pony, I think is the expression.
Jan?
Now, I strongly believe in off-pump surgery in high-risk patients after this study, after the Prague-6 study. And I would say that if I meet a patient with a high operative risk, I would recommend him off-pump surgery, and I will do that.
Michael?
Yeah, I suspect your question obviously was more in America. And I think the best answer to your question would be in the STS database. Now, if I were to speculate from our own observation in our own medical center in Houston, I suspect that across America, this is probably more driven by individual surgeons that have a passion for it. Because we have in our own institution some surgeons that will do 80% of off-pump and others that we might do only 20%. So I think in America, I don't think we have this clear-cut concept of patient selection. I think has been a lot more driven by surgeons' passions. Hopefully this data that we're seeing now is going to bring some sobering news and make people perhaps think more along the ways of who should be better suited for one versus the other.
What we learned from the trial, but we also see in the German data, those institutions who tried to set up an off-pump program, they improved. The best centers in Germany are those that have a strong off-pump group. And there are some, they do off-pump at 80% of their patients. They have the absolutely best results. So to re-engineer your surgical program is one that makes off-pump also attractive for the situation in a country or an institution.
It also has implications for training in cardiac surgery, and I'm sure that training in the United States is different than it may be in Europe. And to get to Michael's observation that the penetration of off-pump surgery in the United States is quite heterogeneous and quite variable, ranging from more than 80% at a place like Emory in Atlanta to less than 5% in most centers in Boston, and how the next generation of cardiac surgeons can become facile at this particular procedure will also hang in the balance, and we shouldn't really forget that. Mark, closing comments on this section?
So as always, pick your patient, pick your technique, and find the best surgeon.
Very good.